All right, we are live. Hey, everyone. Thank you for joining us on Facebook Live for this Pink Table Talk on breast health. I'm Mallory Sofaste with WMAR 2 News, along with 4 healthcare experts with the University of Maryland St. Joseph Medical Center. And I'll introduce them in just a second. But I want to remind anyone watching this, you can participate. We want you to ask questions. This is an open discussion. Anything you want to know about breast health, you have these incredible experts here to answer your questions. So if you have any, just put it in the comment section and we'll get to them. So I do want to just start by introducing our experts who will be answering your questions today. So we have Dr. Suliat Nuruddin, breast surgeon and medical director at St. Joseph Breast Health Center. Hi, doctor. Thank you for joining us. And then we have medical oncologist and medical director, Dr. Kimberly Schlesinger at the Cancer Institute at St. Joseph. Hi, Dr. Kim.
Hey, thanks for having me.
Of course. And we have plastic and reconstructive surgeon, Dr. Erin Rada. Thanks for joining us.
Hi, everyone.
And also breast nurse navigator, Susan Field. Welcome, Susan.
Hi, thank you for having us.
All right. So again, any questions you have for these 4 incredible experts about breast health, put those in the comment section. But I do want to start off by just kind of asking the basics. So what exactly is breast health? We know, to get mammograms, but how often? And is there anything else that women need to be aware of? So let's start with maybe Dr. Nuruddin, and we can kind of just go around and have a discussion.
Absolutely. Breast health is more than having your mammogram every year, every 2 years. We know that routine mammography is extremely helpful when it comes to early detection of breast cancer. And we have long-term data that shows that detecting breast cancer early has an impact when it comes to survival. But breast health it goes even further beyond that. Breast health is knowing what's specific to your breasts and knowing the normal changes that come with your breast. So, we may see changes that come with your menstrual cycle, and you need to know what's normal for you, or quote unquote normal for you. And what's really important is knowing when there's deviation from your normal. And when we see those deviations, those are reasons to alert your provider. So things that we look for, things like new breast pain or new breast masses and, no new nipple discharge. Those are all reasons to call your provider to make sure that any other diagnostic testing is needed and getting those kinds of things done in a timely manner. When it comes to mammograms, well, it's a little bit controversial. So it depends on which organization you talk to be quite honest. Some organizations recommend starting at 40, some recommend starting at 50, some say you should do it every year, some every other year. And it gets very confusing and overwhelming, even for me. And this is what I do every day. And what's most important is knowing your risk and making sure that you discuss with your provider what your risk is so that you can have a screening program that's tailored for you.
Anyone else want to add anything that Dr. Nuruddin didn't cover?
I think for a lot of patients, there can be a lot of anxiety around that process and around getting your mammogram and performing self-exams. And that concept of knowing your body can be difficult for a lot of women. But the process actually, for most people, is really efficient, and we try to make it as comfortable as possible.
I think, too, knowing your own personal risk factors and understanding what you can do to help prevent breast cancer is also very important. And it offers us some reassurance when you take that step to get the mammogram every year.
And you mentioned, knowing your own risk. And that's something that you should probably talk to your doctor about to have that kind of personalized approach. So, how does someone go about that? When should someone mention, if there is a relative or how far, if it's a parent versus like an aunt or a cousin, like how do you discuss that with your doctor?
Sure. Well, hopefully this conversation just comes up as part of your routine visit with either your primary care provider or your OBGYN. But things that are important to understand are your personal history and your family history. So most women actually do not have a family history of breast cancer, but if somebody in the family does have that, it's important that their providers are aware, because hopefully that would lead them to perhaps having early diagnostic testing or even some genetic testing. And the people that we're looking for in the family would be sisters, mothers, aunts, grandmothers, and in particular, if there's any men in the family with a history of breast cancer, because that's also a big red flag. And there are some genetic counseling and testing programs, and we certainly have that here at St. Joe's, that can help identify if there is a gene that runs in the family. And then from there, there's some additional testing that can be done to help identify if you're really at higher risk and what to do about it. But other factors in terms of when you had your first menstrual period, when your last menstrual period was, women who tend to have menstrual periods later on into life, maybe at a little bit higher risk, medications that you've had, any other treatments for other cancers can also play into one's risk. So it's important that women feel comfortable talking about these issues. If your provider doesn't bring it up, then you should definitely bring it up during those routine visits. Absolutely.
All right. Go ahead, Dr.
Well, I was
Nardini.
going to say, I think Dr. Schlesinger brings up so many great points. And I think what the key takeaway is, your risk is personalized for you.
Absolutely.
Now, a lot of patients see me with a new breast cancer diagnosis, and the first thought is, did I cause this? Is this something I did? And, breast cancer, it's multifactorial. So we have to look at all these different factors that all contribute to your individual risk. And if there are things in your history that may change your risk, it may actually change the screening program that we recommend for you. So that's why it's so important to remain engaged with your providers. And, we see patients all the time here in our breast center where we do an evaluation of your individual risk and come up with a screening program that's unique for you.
I know in the last 2 years with the pandemic, screenings have been impacted. A lot of people have, tried to avoid hospitals. Did you guys see a drop off? And I'm sure, it might be concerning. What do you say to those patients who may have put off their screening?
We definitely see a drop in screenings. This isn't just here in Maryland. This is across the country. And, honestly, when you're scared of COVID and an unknown virus, your mammogram does kind of go to the wayside. But, now is really the time to get back to screening. So, we know that early detection is key. If you missed your mammogram, it's okay. Let's get back on track. Reach out to your provider and we'll get you in for your mammogram and we'll get you back on your schedule.
And I think there's some reassurance too, because although we're used to saying every year you should have a mammogram, there is good data that suggests that spacing it out to 2 years is probably going to be just as good. So I think most of us here on the team would prefer we all have the mammograms once a year, but it's okay to do it, to have that space and time. So that should not be a cause for a lot of concern or worry for most women.
That is reassuring to hear, because I do know, I think the longer someone puts something off, the more anxiety that builds, what could be going on. So to hear you both talk so calmly about it and just to encourage people, it should just be a part of your regular, annual checklist, right?
Absolutely.
Absolutely. And this is a judgment-free zone. If you missed your mammogram, it's okay. You come in and get your mammogram now. It's perfectly fine. We just care that you're maintaining your breast health.
Perfect. And just a reminder, anyone watching, comment with your questions. We will ask them now. And Susan, I want to bring you into this conversation. So you have a very important job as a breast nurse navigator. So tell me a little bit about what that entails and what exactly happens after a breast cancer diagnosis.
Susan looks frozen.
Is she frozen? Is that why she's been so quiet?
I was wondering why she was so still.
She's thinking now at the spinning wheel.
Okay, we'll come back to Susan because that's such an important aspect of it as well. And Dr. Rada, on the topic of, is she? Oh, I see her in the background.
Oh, now I'm jealous.
I'm sorry. I'm really sorry. I couldn't hear anything. It was like everybody was underwater.
Oh,
So I apologize.
Well, welcome, Susan. Okay, we don't want your head covered by the emblem.
here, I'm going to have you come a little. Oh, good. Thank you.
Oh, there we go.
Thank you.
Well, perfect. Now that we see you and hear you clearly. So I was asking, about your important job as a breast nurse navigator, and what happens when someone does receive that diagnosis? What are kind of the next steps?
Well, you can imagine what a whirlwind it is for our patients, and that they hear virtually nothing that we say. So I pride myself in being, my daughter says I'm their BFF. I become a question answerer, hand holder, and the person that I like to say can help our patients through their journey. I talk to them on the telephone, they email me, I have what I call touch points. So I try to get in touch with them periodically so they know I'm thinking about them. I see them when they're here at the Cancer Institute. And I am proud to be able to share the different resources that we have here at the Cancer Institute. We have an amazing wellness and support center that I make referrals for all of our patients. We have a really amazing rehab center as well. All of our patients are evaluated in the physical therapy program before they start any form of treatment. And I'm also the coordinator for a program that we have here. It's called SOS, which stands for Survivors Offering Support. And I try to connect our patients with a mentor, someone who's been there, done that, someone who can say, I know what you're going through because I've been down this road. And so there are lots of opportunities that I can touch our patients, and it gives me pride every day to be able to do that.
I love that description as a BFF, and I can only imagine how important that is, because I've had friends and family who have these important doctor visits, and they're trying to scribble down all the notes they can, but they go home and they think of questions that, man, I wish I'd asked that, and it can be a hard process. Doctors are so busy, so to have someone like you that they can just get a hold of immediately, I'm sure it's just vital.
Yeah, and you know what they say sometimes? Oh, I knew I could call you. And it tickles me that they, instead of floundering and wondering, who the heck can I talk to? And I don't know where to turn. And I have this question, and what should I do? They know they can always call me.
Or worse, they go to Google, they
Oh yeah, we say
go down that rabbit hole.
Right. And that's really terrible, because I think Google is wonderful, lots of really wonderful information, but also lots of inaccurate information for a patient and their specific diagnosis.
All right. And Dr. Schlesinger, or I'm going to actually go to Dr. Rada, because I do want to talk about the other aspect after a diagnosis. So when exactly do you discuss with a patient about breast reconstruction, and what are some of their, questions or their most common questions?
I think that Susan really hit the nail on the head. This is an overwhelming process, getting that diagnosis and having to contend with making a lot of decisions in a relatively short period of time is difficult. So patients will often come see me after they've met with the breast surgeons, and it's been determined that they will have surgery. And the breast surgeons are really amazing at trying to get them plugged in to see me early so that we can start that conversation. Because the great thing about, I feel really lucky also to do what I do. It's a little bit of a silver lining in their journey often. But initially, some people have an idea of the options for breast reconstruction, but there really is a wide spectrum of possibilities. So a lot of that initial visit is about getting to know one another and doing a little bit of education to give them an idea of the possibilities.
And what's the recovery like? I'm sure people have questions about that.
Recovery varies based on what operation a patient is having and whether they're having reconstruction or not. But what we really try to do at every level of a patient's care, whether it's with Dr. Schlesinger or Dr. Nuruddin with Susan, we really try to meet the patients where they are. So every patient's care is different. Every patient's journey, I don't mean care is different, but every patient's journey is different based on their diagnosis and based on their choices and preferences. So in that initial visit, in addition to trying to get to know patients a little bit and educating them about the options that they have, my goal is really to understand what their goals are, because we want to get women feeling confident and happy so that they can move past this?
I think Dr. Rada brings up such an amazing point because a breast cancer diagnosis is so overwhelming. And a lot of times I find that patients make treatment decisions in the moment and forget the fact that you have a long life to live ahead of you after you're done with this breast cancer mess. You have so much more life to live, and we need to make sure that when we're making decisions about your care right now, we're taking into account your quality of life, what you want your body to look like in the future, and that we're not making decisions that you would have any regret of later. So we want to make sure that you're fully counseled. We do a lot of repetition, which I'm sure patients are like, you already told me that. Why are you telling me? But, it's just repetition is key. We really just want to make sure that patients have all the information and that they're going in making a decision that they're comfortable with.
And we have a question from Emily Adams. This is a great question. Any recommendations for how to best support a loved one with breast cancer?
Oh, that's a great question. Susan.
What knowledge is power.
Yeah.
And I tell our patients, is there someone that can come with you to your appointment? And luckily, we've had some COVID restrictions, but we do allow one person to come with our patient for the consultation appointments. And 4 ears are far, far, far better than 2. And then the patients say, can my daughter call with questions? Because I know she will have questions. And I say, with your permission, of course, I'm happy to answer and support the whole family. And which leads me to something else, is that our Wellness and Support Center has some amazing opportunities, such as meeting with a nurse practitioner. A nurse upstairs does something called Healing Touch. We have a social worker, we have a dietitian, there are yoga classes, there's acupuncture, and family members have access to this as well. So it's so important that the caregiver is an active part of the team in taking care. It's not just in terms of what we take care of, a breast. It's the whole picture that we're here to support.
Absolutely. And I would say that many women after surgery still need some more treatments, whether it's in the form of an anti-estrogen pill or sometimes chemotherapy. And I think that having that provider support or caregiver support is very important. But one of the key things that I think we would all agree on is that the most important thing is just being present and listening. I know for myself, sometimes it's easy to rush in and try to fix it. And this isn't something that is, regardless of how much you love the person, this is going to be their journey, and being there to support and listen without trying to fix everything, but also trying to normalize. Don't avoid going out. Don't avoid the restaurants. Try to keep in there as normal a routine as possible. That's also very helpful for the patient, just trying to normalize daily life.
You bring up such an excellent point because, say it's a friend or a neighbor and you don't really know what to say.
I think just having that normal conversation, acknowledging, hey, listen, I'm here to talk, or if you want to go for a walk, but what else is going on? Just talk normally, naturally. And that's what patients, they want to have a normalization in all of this, and being able to provide that is important.
Now, I don't want to exclude men, because I do know that we do have a small percentage of our patients that are male breast cancers, but I will say the vast majority of patients that we take care of are women. And as women, we do tend to take on a lot and tend to be the support system for a lot of people. And I tell my patients that this is your time to allow other people to support you. You've been doing it for so long, and it's a very uncomfortable feeling. I know, because I've been in that same situation, and it's a hard thing to let someone else support you. As their family member, their caregiver, it's just so important that you give them that space to just let go and let other people support them as they get through this journey. So I think that's going to be key in terms of supporting a newly diagnosed patient.
And we have another question from Kelly Groft. There has been talk in the news about dense breasts and cancer risk. Can you explain this? Whoever wants to tackle it.
I'm happy to start. We see that the density of breast tissue tends to decrease in age. So women that are younger tend to have denser breast tissue. And what that means when it comes to breast imaging is that sometimes on mammography, it can be a little bit more challenging to visualize all of the breast tissue, and it may obscure underlying masses and things like that. Now, with that said, in about, I think it was 2013, it was a requirement that all mammograms had to report on breast density. So prior to that, you didn't hear anything about your breast density. And then you were hearing about your breast density every year, and everybody's like, oh, my breasts are dense. What does that mean? And, so it's variable what exactly breast density means in terms of that classification. But it's also important to engage with your providers to determine, is there any role for any other imaging in addition to my mammogram? Because if there is a certain level of density in the setting of also other strong risk factors, it may mean that other screening modalities may be indicated, such as breast ultrasounds and in rare cases, even breast MRIs. But I think what's most important is knowing the results of your imaging reports and making sure that you're comfortable with those results and engaging with your providers if there are questions.
And two, I think that's where the specialized mammographer comes into play, because somebody who's experienced in reading the mammograms and has a sense for all of this may be able to step up to the plate and tell either the patient or the ordering physician, hey, I think we need to do maybe some more images, or it's time to do the ultrasound like Dr. Nurdine was talking about, or an MRI. So it really becomes a team effort way back at the beginning with screening.
And Susan, you had mentioned earlier about a program, SOS, I believe, or around survivorship or being able to speak with survivors, because yes, everyone wants to, make their own decision and what's best for them. But I'm sure it's key to also be able to speak to women and men who have been through this before.
Patients really love it. And really, the day that I meet the patient, I tell them about our program. And I say it's available today, tomorrow, next week, next month, next year. And I say it's really available 5 years from now, anywhere along the continuum. Sometimes patients, when they're survivors and they're years out of treatment, say, you know what, I'm really struggling because now I have fear of my breast cancer coming back. And they say, what can you do to help me? And I am happy to connect them with the survivor who can say, I know what you're going through because I walk this journey daily as well. And so I really feel privileged to be able to support our patients in all facets of their breast cancer.
And speaking of, moving forward and after a treatment, Dr. Schlesinger, you kind of talked about this briefly, what needs to be the plan after that? It's something you probably always need to be cognizant of.
So here at St. Joe's, we work really hard to develop a survivorship and surveillance plan for all of our patients, whether they just have surgery or whether they move on to have systemic therapy like chemotherapy or a pill or radiation, anything along those lines. It's really important that at the conclusion of that time, there's a plan in place for how to follow. The majority of patients will continue to follow with their surgeon for many years and will continue to work with medical oncology to make sure that we capture if there are changes. And I think one of the key points is that when somebody's in that surveillance period of time, there's going to be a lot of concern that every ache and pain or cough could reflect the cancer coming back. And that's a very normal concern. But what we try to do is educate our patients on what a real red flag is. But we have a low threshold for bringing patients in, looking into whatever symptom they're having and making sure that it is just a cold or a pulled muscle. But to Susan's point, that's really where the support often comes in later on down the line, that concern about what if or what is this. And so we really tailor the survivorship and surveillance plan according to the patient's need. Some patients require a lot of treatment after their breast surgery, and some people don't. So how we view them and how often we see them is really tailored to their risk of recurrence.
Great. And just one last kind of call for questions while we are live. And then I believe also too, once this wraps up, you can still comment with any questions and we'll see if we can try to get those answered for you. But this is your opportunity to ask them live while we have these incredible experts. And we are doing this, of course, in October because it's Breast Cancer Awareness Month. And to Dr. Schlesinger's point earlier, we want to normalize this and just have an open conversation. And I think it's also important, you know, technology has changed so much. And what does it mean to be able to catch a diagnosis very early on?
So we know that early detection of breast cancer has huge impacts when it comes to survival. Early stage breast cancer, which is considered stage 0 to stage 2, we see significant differences when it comes to survival compared to later stage cancer. So that's why detection truly is key. In addition to mammography, we have improvement in terms of our systemic therapies and our radiation treatments. All of these things have kind of come together to improve our cancer outcomes. And, you know, in general, patients do very well now despite a breast cancer diagnosis.
And there's also preventative measures that we can use if we identify somebody who meets certain criteria. And these criteria are pretty basic, but it includes genetic predispositions, like we talked about earlier with genetic testing, but also personal choices in terms of when your first child was. I mean, they sound kind of nebulous, and to some degree they are, but there's algorithms that the providers can sit down with the patient and sort of come up with a rough estimate of the patient's risk of developing breast cancer. And if they reach a higher threshold, then there are medications that we can use to potentially reduce the risk of breast cancer. But that's really a very specialized discussion that the patient needs to have with their provider, and then ultimately, typically a medical oncologist who would prescribe those medications. So it's all about dialogue. It's all about learning your personal risk and really taking those steps to do everything you can to prevent it.
And I am curious on your all's take on, you know, some of these at-home genetic tests when you see that you may have been positive to be predisposed to breast cancer. What do you do with that information?
I've actually had some patients who came to me with one of the at-home kits. And in this one situation, the genetic result that they had did not make sense. So we actually retested them with 3 medical labs, and their tests within the medical lab setting were all in concordance, but were different from the home test. So I caution people, when you get a home test kit and it gives you this diagnosis, it's really incumbent to reach out to a trained cancer geneticist to vet that and consider being retested. So I always warn patients, if you're really interested, let's go through the more rigorous channels of a professional genetic counselor.
Excellent information. Well, is there anything else that anyone would like to include that we haven't covered that you think would be important to discuss today?
I would say, I don't think you can go to any cancer talk or breast cancer talk without having somebody remind you, don't smoke, limit your alcohol, exercise, eat right, get good sleep. I just have to throw that in as medical oncologist.
Absolutely. I can't hear it enough. So, all right. Well, thank you so much for your time. We really appreciate it. And if anyone has any other questions or wants to learn more, they can go to umstjoseph.org/breasthealth. So thank you again for joining us and for your time today. We really appreciate it.
Thank you for having us.
Thanks for having us.
Thank you.